Well, hello and welcome everybody. I'm Dr. Simon Koss. I'm Microsoft's Chief Medical Officer, and it's my very great pleasure as co-chair of the Global Commission to End the Diagnostic Odyssey for Children with a Rare Disease to welcome you here. If you're joining us in person, thank you to all of the Global Commission members that I see here in the audience. If you're joining us from Rare Disease International, thank you for taking time out of your conference to be a part of this. If you're joining us from Brussels, where we're live streaming and bringing them into our conversation for the launch over in Europe, or if you're joining us on the web, thank you and welcome. This is such a momentous day. We've been working for about 12 months now as the Global Commission, and we came together to say this is such a complex problem around the world. It is bigger than any one organisation can solve. Let's take off our corporate hats or our individual hats, and let's come together to think about how we might be able to reinvent the future of diagnosis of children with a rare disease. So we polled together a commission that was very varied in its membership. We had people from the life sciences industry, esteemed clinicians from the genetic space, patient advocacy folks, and technology to say, we each bring some expertise, but let's look at rare disease and how we handle it today with a critical view, and let's think about how we might be able to do that differently. For myself, as a clinician who moved into technology 17 years ago, to understand where the constraints and bottlenecks are today for children with a rare disease, where it can take on average 5 years to get a diagnosis, where people have to go see 7 different providers and 40% of them are misdiagnosed. When you think collectively that some diseases are so rare that providers will never see them, but taken holistically, there's almost 350 million people living with rare disease around the world. They all have families and carers. This is a huge societal issue. So for me, having a look at how it is handled today, we're practicing a model of care that was established a century ago, and we really haven't tapped in to the modern technologies that can make a difference, from virtual care and telemedicine technologies through to digital record technologies and artificial intelligence. These are all potential solutions to some of our constraints that we have today. And it's been enormously gratifying to be a part of some of the trials, to see that the recommendations that we release today are not just paper-based recommendations. They are being lived in pilot programs around the world. So I hope you welcome us with the same enthusiasm that we have for the journey ahead. I'd like to introduce you to my co-chair, Jan Lecam from EURORDIS. Thank you.
Thank you, Simon. Thank you for the slides. Sorry, I went the wrong way. Okay. Yeah, here we are. So good morning, everyone, and good afternoon in Brussels. The Global Commission to End this Odyssey of Children with Rare Diseases was initiated through 2017 and was launched last year on Rare Disease Day 2018. I'm proud that just a year later, on Rare Disease Day 2019, we're publishing this first report. The Global Commission goal is to enable children to have their diagnostic faster and accurate. Faster and accurate. We're waiting years to have diagnosis. 5 years on the average, even in regions like Europe. And accuracy is important because what we want to address is to reduce the number of undiagnosed children, but also of misdiagnosed children. Misdiagnosis is making us suffering and killing some of us. What is unique about this Global Commission is that it brings together the actors from different fields of expertise in health and beyond health, and that's really the value of this commission. And I'd like to thank our colleagues coming from the horizon of digital industry and technology. We wanted to explore the new potential of digital technology, of artificial intelligence, of web communication and social media, but in addition to the new sciences in genomics and how we can combine them and optimize with new approaches. But I would also insist that it goes together with innovation on the organization of healthcare. That goes together. Getting your diagnosed needs, then after that you need to have access to healthcare in order to have access to a care, not just to be stuck with your diagnosis. Our approach has been to focus and will continue to focus on actionable, so concrete steps in order to address barriers and challenges. The Commission is composed of experts, as you can see here on the slide, of patient advocates, and I'd like to thank them. And I'd like to say that here in New York today in the room, we have patient advocates from over 40 different countries and from all continents. They are from Botswana to Malaysia, from Brazil to Russia, from Croatia to Hong Kong. And thank you for being here for this event. Also in the group, we have leaders from the academic and scientific community. And these leaders are not top scientists. They are also leaders of networks, of learned society. So all the people in this commission were in a position to synthesize existing proposals and new knowledge, and that was the purpose of the group. They were able to anticipate and synthesize. The Commission met 3 times in 1 year. It's a huge effort, and we've been performing a state-of-the-art of the technology, but also of the policy, and we collected inputs from the community, particularly on the solutions, from the patient community. We had also, needless to say, strong support from the extended team of the 3 organizations, Microsoft, Takeda, and EURORDIS. With this, and before handing over to our co-chair, Wolfram, from Takeda, I'd like to welcome online in Brussels, Manuel Mateo, who is representative of the European Commission, Digital Economy and Society. Thank you very much for being with us, and thank you to all panelists in Brussels for your participation. Wolfram.
Well, thank you very much for coming out today and joining us for this important event. As you know, I joined this group a little bit late, and I've always been involved since the beginning in the background. But this is a really unique opportunity, and I'm really humbled and privileged to work with all of you in this multidisciplinary fashion. And I think it's a really great opportunity, something really impactful, something we need to demonstrate for the future to our folks, our patients, everyone, that this is really changing the lives of our patients and making our life easier to communicate what we want to do, to diagnose patients. And I think this is a really unique opportunity for all of us. So I look forward to working with all of you in making this happen, and hopefully, it's going to be for many years to come. And we will hopefully be, in a position that everyone is envying us for what we do and learning from us and really implementing it in their daily lives. So today is really to celebrate the launch of the Global Commission 1-year report. And also I wanted to acknowledge another colleague of mine, Charles Platford, who is also at the Brussels event. He's the president of our European and Canadian business unit and also a member of the Takeda Executive Committee. So they're all in Brussels today. I hear they had a great meeting, and hopefully they can, see us and hear us at least, and everything is going well in Europe. As Jan mentioned, it was just 1 year ago that Takeda, and at this time it was Shire, and as you know, there's a lot happening in 1 year, together with Microsoft and EURORDIS, announced a joint effort to address the issue of rare disease diagnostics in children. We gathered together a group of multidisciplinary experts and charged them with developing a much-needed roadmap in the field. And we asked them to do this in just a short 12 months. We believe that with this wide range of perspective, experiences, technology, expertise, and creativity, they could tackle one of the most heartbreaking challenges for rare disease patients, the diagnostic odyssey. I am proud to announce that in the 1 year we have identified the major barriers to diagnosis and developed actionable recommendations. And I think that is really the key word, actionable, to overcome these barriers. Many of these recommendations address challenges that are distinctive to rare diseases and the technology is uniquely equipped to solve. We understood that the problem of diagnosis is multidimensional and one fix wasn't the answer. We instead organized the solution ideas into 3 distinct yet interwoven tracks: empowering patients and families, equipping frontline providers with tools for diagnosis and referral, and reimagining the genetic consultation. And for those of you who have looked through the report, it's a really nice summary of what we want to do, and it's outlined really perfectly, finding the right balance between science and something which is really understandable for a broader audience. So it's a really wonderful report. In order to create an enabling environment for these ideas, we've identified several global policy recommendations that can be implemented at a local level, as Jan will point out later in more detail. And lastly, we wanted to test out some of these ideas. We have 3 active technology pilot programs that are designed to provide proof of concept and hopefully open doors for expansion and future collaborations. The goal of this report is to inspire concerted action and mobilize diverse actors within and outside of the health field to implement these solutions and improve the lives of millions of children with a rare disease. We hope that you can find something in this report which relates to you. Your action will help the field move closer to bettering the lives of children and their families. As champions for the millions of people living with a rare disease, this partnership is a step in Takeda's own journey towards transforming the lives of children and families, and we are proud to be a co-chair of the Global Commission. Before I turn it over to the panel, I would like to thank the members for their commitment and ideas, a cross-functional team of colleagues at Takeda, and the teams of Microsoft, EURORDIS, and Reverend Martin for all their hard work. We already heard about Lynn and all her great contributions, but I want to thank her again in particular for all the great work she's done. She's worked for the last 2 years, and Lynn, special thank you. And you really, helped us to accomplish and be there today and really forge ahead with our global partnerships with diverse institutions and communities. So thank you, Lynn. And with that, I would like to hand over and welcome Mike Porras, who is a Global Commission member, also founder and CEO of the MIDI, and the board member of the DUPE, 15Q, just learned about the DUPE, and welcome to the team.
Thank you very much.
Thank you.
I could get the clicker. Thank you. It's really a privilege to have been on this commission and be with you guys today. 10 years ago, we were on our own diagnostic odyssey. My family, I've got 3 kids, and my oldest, we knew things weren't quite right with Annabelle and our daughter. And we got a phone call finally after 2.5 years of working through this, and the doctor on the phone said it's unlikely her mind is going to develop beyond that of a 5-year-old. And we got the diagnosis. I can tell you that day, that diagnosis felt devastating. But since, coming through all that day was actually liberating. Because once we had the diagnosis, we could find the community of people who were handling this. We could find the right doctors who knew more about this. We could mobilize as a community, and we're at the point now we're starting with clinical trials to actually develop treatments for people with this. So that point of diagnosis is so important. I know it has been for our family. It led us to the DUPE 15Q Alliance, ultimately creating a health community called the MIDI, which has millions of people trying to share their experiences with each other and hopefully get people to answers much faster. So there's another dad here that we're going to show a video of, Julian in Spain, who has a great story here. And you're going to first watch the video, and then you're going to hear a little bit more from one of his colleagues at Microsoft on what he's doing really to help provide a solution here. So let's click through.
Sergio, like other children with rare diseases, is a child who needs 24/7 support. When Sergio had the first seizure, we didn't know what happened. We ran into the emergency room. We ran into a lot of testings. We spent a lot of time, a lot of money visiting specialists, because when you don't know what's happened to you or your family, you try to find an answer. We spent 6 months until having the final diagnosis. The problem of this gap for the proper diagnosis is that we put Sergio in a bad treatment for Dravet. One day he had 20 seizures. We just stopped counting. Statistics say that the average patient with rare disease, they need to visit 7 specialists until having diagnosis, and the average time to diagnosis is 5 years. Diagnosis is important, not just for treatment, but also to find a group, find a community, a place where you can share your pain, share your problems, and get answers. The Global Commission is a global initiative. The ultimate goal is to create recommendations to try to improve the time to diagnosis. When the Commission was founded, I talked to the representatives on this global initiative and I asked them to be involved. I created this non-profit organization, Foundation 29, with the focus of using technology to improve life of people with rare diseases. When you have a child with a rare disease, and because your life is going to change, the company you work with is very important. I feel lucky because I've been working in Microsoft for 20 years. Microsoft has a lot of flexibility to allow people with a particular problem to focus on what is important to them. We won't be able to find a treatment for Sergio, and we won't be able to make Sergio will be healthy and normal, but our energy and the work we are doing in our family is focused in order to avoid the situation for other children. If we are able to help other children and we are able to diagnose these children early and avoid the same situation that we have for Sergio, this will be great, because our life will have a purpose. We won't be able to make Sergio healthy, but Sergio, in some way, will be able to help so many people. This is our motivation.
So Dr. Clifford Goldsmith is going to come up and tell you a little bit more. You saw the beginning of Julian's story, and Dr. Goldsmith is going to help. Here's the clicker for you. Take you through more of what he and the work of his foundation is doing at Microsoft.
So thanks, Mike. It's great to be here with everybody and to be able to tell Julian and Sergio's story in a little more detail. It's one of the pilots that you saw mentioned, that Wolfram mentioned, the pilot number 1. And I'll say much more about it, but the work of this pilot that we've been supporting through the Global Commission and encouraging has been done in Spain at La Paz Hospital, and it's now being expanded beyond that. So I'm really repeating here what Jan said, but 5 years to diagnosis is far too long. And 40% misdiagnosis on the first diagnosis, and often more than that, is far too inaccurate. The goal of this pilot is targeted at the track 2 that you saw of the Global Commission, which is all about equipping frontline physicians to make diagnoses more accurately and faster. So I'm going to go now to the pilot itself, and I'm going to actually start the pilot up. This is running on a live site, so we're taking a real risk over here. And I'm going to do it now because it uses machine learning. And in doing machine learning, it's got an algorithm that it needs to run that can run for about 3.5 minutes. So I'm going to start the algorithm. I'm going to tell you what it's doing, and we're going to go back to it afterwards. As you heard from Julian in the video, he's a Microsoft employee. He started this foundation, has been supported by Microsoft in the work that he does, and has been doing and continues to do. And you'll also notice that this site is actually running in the Microsoft cloud, in the Azure cloud. I'm going to choose a new patient. And all I need to do for a new patient is put in one or two primary reasons why I'm concerned about this patient and why I went ahead and did next generation screening, sequencing on this patient. So it's just one or two. I don't have to do the complete diagnosis. So I'm going to start off by putting in febrile seizures, and I'm going to put in a second diagnosis of status, or a second presentation of status epilepticus. And then once I have the symptoms, I'm going to upload a processed file that's been processed from next generation sequencing and put into a variant format with all the mutations for this patient. And I'm going to open that file, and I'm going to let it run. So this is the process, the machine learning process running. If we could switch back to the slides while it's running. So today, the current process that we go through is far too single-threaded. What happens, I know as a physician in my training, that you work up your patient completely. You do a full symptoms, full signs, decide on your observations, and then ultimately work out as many of the issues that you can so that you've done all the work before you pass this over to some specialist or some diagnostician. And what happens in most of the processes is when all that data is passed over to the diagnostic team does their work, and what comes back, and this is typical not just of genomics, but it's typical of many tests in medicine, what comes back is a report, something like this, that I then have to work through to try and make sense in the case of my patient's clinical presentation. In a multi-threaded approach that you're seeing here, what you're seeing is something very different. Once I have one or two primary symptoms, you saw me enter them in, febrile seizures and status epilepticus, I then have the genome sequencing, and I put those two things together. What's happening now in the background, as this process is now running, it's taking both the phenotype and the genotype together and is going through those two together, going through the symptoms that you've given it, and extracting either off-target mutations, common mutations, unlikely to be clinically relevant mutations, and it's also prioritizing in the background all the clinical mutations that are in that sequencing, that sequence file that I put there, and making it relevant to that diagnosis. What it's going to do when it comes back to me in a moment, it's going to offer me further symptoms that I can then enter. So what this means too is that I don't have to know, as a primary care physician, every diagnosis and every presentation of every rare disease. I am going to the computer is going to come back based on the prioritization of the mutations and give me options to choose, and I will choose the few more symptoms that we know patients like Sergio with Dravet's disease have. Once that's done, the computer will then go off again, the program or the tool will go off again, and using this expanded list of about 10 to 15, which is what it requires typically, could give it more, typical symptoms or phenotypes or presentations, it will then use the genome again and come back with a list of prioritized recommendations for the diagnosis. What's important about this is not a diagnostic tool. We're not suggesting this can make the diagnosis. This is a clinical tool that supports clinicians in that process. And we'll come back to what that means to Sergio. So if you could go back to the pilot. So it's finished processing. And what it's got is it's telling me it's got two phenotype qualities already that I gave it. And it's telling me that's a pretty poor range of symptoms for using this tool effectively. I can then choose a few more symptoms. What's nice about this is it's doing two things. It's actually, one is I don't have to know all the symptoms, and I'm not even interested at this point in what the mutation was. I'm much more interested in what the symptoms are that I'm putting in. But it also gives me information, you can see, that I can learn from the system as well. So it's a tool that not just helps diagnosis or helps the clinical process for a primary care physician, but it also educates them. So I'm going to choose a few more conditions based on what I know that my patient has. And I'm going to go to the next mutation at this point. And I'm going to choose a few more from this screen over here. So I'm going to add a couple more over here. We know that the patient has an abnormal EEG, sorry. And I'm going to add a few others down here. And then I'm going to, for the sake of this demo, I've chosen about 11 symptoms, and I'm going to say I'm finished. And what it's done, the tool, has now gone out and prioritized, and I'm going to point this out to you on the screen here. You can see this over here. It's gone out, and with that set of symptoms and the mutations in that file, it's gone out and prioritizing. You can see it's still running. In 4 different ways, it's prioritizing the diagnoses. And you can see it's just completed, and Dravet's syndrome came to the top. It's classified the number of symptom matches. So there were 8 symptom matches in this case out of the 11 that matched Dravet's disease. There, you can see here that there's a phenotypic score for each of them under this category over here. And there's a genome matching score as well. And then ultimately, this tool, and these are publicly available tools that are being used in the background that are running as services in the cloud. This tool itself, the Health 29 tool, has given an overall rating. But what's really, really important about this at the moment is that while Dravet syndrome comes up with a 100% genome match, 3 other conditions come up with a 100% genome match. And they all need to be considered. And actually, you heard Julian say this to you in that video. They considered, I believe, one of these other diagnoses in the first case with Sergio. And what that means, unfortunately, is that 2 treatments can be diametrically opposed. And it actually exacerbated the epilepsy that Sergio had. So this kind of tool is important. This tool is far from complete. It made a lot of progress over the last year. But this is exactly the kinds of technology that the Global Commission is shining a really bright light on, and that we all need to shine a bright light on, in the hope that these kinds of tools can reach the point that they can become clinically relevant and useful to all of us. If we could switch back. I think the most important thing to remember is that technology is one thing, but behind every technology and every tool that we think about, there's a real patient like Sergio, there's a real family like Julian and his wife, and they are waiting desperately, like Mike said earlier, for a diagnosis. Thank you.
So, yeah, at this point, we want to welcome a few panelists. We're going to have a discussion. You guys can come on up. And I'll let them all introduce themselves for a minute or so, give you a little bit of their own background, the roles that they play. These are all commission members. And go ahead. And we'll have a discussion. I've got some prepared questions, but I hope it really turns into much more of a discussion. We'll also open it up to Q&A as we get through some of this. So, Marshall, why don't we start with you and come across?
All right. My name is Marshall Summer. I kind of wear 2 hats. One, I run the Rare Disease Institute at Children's National Medical Center, and I have the privilege of being the board chairman for the National Organization for Rare Disorders.
Durham Walreefer. I am the president and CEO of the Canadian Organization for Rare Disorders, and also really pleased to be the chair of the Council for Rare Disease International.
I'm Sarah Lee Hughes. I'm a haematologist, a blood doctor by training in London. I work at the Royal Free Hospital in the lysosomal storage disorders unit. So I look after a group of patients with rare genetic disorders, but I'm also involved in other rare disorders such as cancers and amyloid throughout the hospital.
And I'm afraid I didn't introduce myself at the beginning. I'm Clifford Goldsmith. I'm a physician by training. I'm the National Director for Microsoft's provider industry in the US.
Yeah, I'm going to put this.
No, I just put it down.
Thank you.
So first question, Marshall, goes to you. One of my takeaways of being part of this commission was learning how few geneticists are actually out there. In many of the developing countries, you have 1 geneticist for every 3.5 or 4 million people. So how can we bring technology into these? We talked a lot about pre-appointment consultations, so that patients can be seen by geneticists faster, and that the families get a lot more information out of them during those consultations.
Mike, that's absolutely a great question and actually key to my field. It's not even can we or if we should, we have to at this point. The supply of geneticists who are the primary diagnosticians for a lot of the genetic rare disease versus the number of patients, and with all of this new information, all of the stuff coming from sequencing, all of the new clinic. I mean, when I started, you could diagnose 13 diseases. Now I can diagnose 8 to 10,000 diseases. And how do you keep up with that? Without a digital backbone, for a lot of that, you can't do it. The other thing we have to do is we have to start pushing things back to primary care. There's a real shift in medicine over the last 20 or 30 years as people sent patients more and more to specialists. Well, in a limited pool of specialists with a field as big and wide as rare disease, we actually have to have our primary care providers involved. So tools like 29, tools like digital opinions, basically where a physician can get a quick read from someone on this patient needs to get engaged, this patient doesn't need to get engaged. Because right now we're using kind of what I would say the fruits of 1960s technology for this. So we've got to put these digital tools in place. We've got to push them back to the primary care providers. We need to make that bridge between them a lot shorter. We should be spending 30, 40% of our time directly communicating with those early providers rather than being at the end of this very long process where patients have gone through so many iterations. And we call it the lather, rinse, repeat cycle. You come in, somebody has a bright idea, they test it, it's right or wrong. If it's wrong, you go back, you have another bright idea. We need to condense that process significantly. Using these digital tools is one of the best ways to do it because we literally don't have the personnel to do it.
Mm-hmm. And that actually flows to Derhan on looking at it from the parents or patient's perspective. Why is it important to empower these patients to work collaboratively, with their physicians, with the geneticists, and how can technology play a role in that as well?
Yeah, hugely important, Mike, and I think your story obviously illustrates some of the challenges that patients and parents have. And I think, and you're talking about living in a very developed country, and certainly for me as well in Canada, but we're also recognizing the fact that there are so many patients that live in countries that are much less resourced. I mean, obviously there's the internet that will help us, and I think that is sort of a major technology. And I love the fact that the first track that we recognize on there is empowering the patients and parents. Because what we know is that in many cases, you talk about that, 5 different misdiagnoses, or you talk about all the many years to a diagnosis. It's really patients and parents that continue to push that even get to a diagnosis. So, the whole notion is how do we put more tools into the hands of the patients? And there's some there now. I just will digress for a second. I really never talk about my own situation, but my daughter, born 34 years ago, presented with a whole bunch of unusual symptoms, both physical and cognitive. And they basically said to us, we have no idea after numerous tests. We'll wait. When she's about 2 years old, she'll either stabilize, she'll either get better, or she'll get worse. Oh, well, that was kind of interesting. So that was fine. And then we did actually end up with a diagnosis of actually thalassemia, about 2.5 years into it, but was unrelated to everything else that she had, right? So that's the other thing we learned, right? Just because you have one rare disease does not, kind of avoid other rare diseases. And then many years later, when we get the genome sequence and we're kind of like, oh, this is great, maybe we can find out, kind of what it is doing some kind of genetic testing. The challenge we learned at that time was that because she's adopted and we have no family members to match her against, we can't figure it out. Now I look at this and I say, yes. Not now that she's 34, she can decide whether she wants to get genome sequenced or not, so that's a whole different question. But I think it's being able to, as you say, to take this technology. And we're really excited by some of the tools that give patients, not just going on to Google, right, and figuring out, but very specific portals that allow you to do some of that demonstration that you had. How do we bring some of that to the patients at a level where they can go back to the doctor and say, here's what we're learning, here's what we're finding out, here's what we need you to help us do in terms of taking the next step. And I think that's the power of it, right? So that parents and patients can not only get and feel more empowered, but they actually can bring real knowledge to it. And that is what we see is actually available to probably everybody. And our goal is to actually, I sit also on the board of the Asia Pacific Alliance of Rare Disease Organizations, who have some of our members here, and they can talk to you about the exquisite challenges of living in countries where you don't get easy access, or people that live in rural areas, et cetera. So we're truly excited that, by being able to harness some of the things that we're talking about here, and certainly, the support networks, but also moving into technology. So this for us is a hugely, I think, big step. And as I said, I'm thrilled that what we're looking at is track 1 is how do we empower the parents and the patients so that we can get physicians like you to basically say, no, you're not crazy. We actually can help you.
And I encourage everyone to actually go and read the report. A lot of work went into it. You're hearing snippets of it up here, but I really encourage you to go to the website and read it. One of the things that struck me most is I work with Darhan closely around the patients and the just in terms of really empowering them and the families. And what struck me is we came up with the questions that they should be asking themselves. If you have a child who's just struggling in a lot of ways and you're not getting the right answers, and then there's questions trying to empower them to have conversations with doctors. And I think we need to get these questions spread out and for people to really acknowledge them and to empower the patients to ask them. Nobody told me that I should be asking these questions when we were going through it, and they probably would have gotten us a diagnosis much faster. So Darylyn, John brought up genome sequencing, brought up technology. Can you discuss a little bit about how the Global Commission envisions using artificial intelligence, AI, as a tool for first-line providers to help shorten that time to diagnosis? We talked a little bit about it today. I want to take the conversation we had and share it with everyone this morning.
So this has massive power to go some way to overcoming that paradox of increasing information globally about all medical disorders, but yet with rare disorders, a few people disparately scattered around the world with their own little packages of information. And how do you bring that together so the patient in front of you has the benefit of all of that global shared learning? So let me try and illustrate that with a thought about a patient. So imagine little boy Joe out in rural England. His mum thinks he's not developing quite as quickly as other members of the family. Takes him to the family doctor, who of course says, well, go away for a few weeks, come back to me, it might all get better. In the meantime, things progress, things are noticed at school. The GP then, or his family doctor, says, okay, we'll refer you to the paediatrician at the local hospital, by which time he's had his first seizure. He goes into the local hospital. The paediatrician tries to pull the information together, but it doesn't quite fit with anything that they have seen or encountered. Things carry on getting a little bit worse, and they refer them to a specialist centre. Specialist centre says, oh, this fits maybe a little bit with disorders that perhaps Dr. Hughes has seen, so they come to see me. Mum comes with a great stack of information that she's picked up at all the different consultations. But of course, it's her side of the information. I don't see the medical side from the hospitals. So the first thing I do is probably repeat most of the tests they've already had, because I don't really know what's happened, and I add on a few more. They all come back negative, but it gives me a little bit more information, and I refer on again to the next person who I think this maybe fits a little bit more of. In the meantime, Joe has some genetic information. It's sequenced, and we find that he's one of 6 children in the whole world who have a condition. So what do? Well, I write it up. I get my fellow to write a case report, and it goes into the literature so that somebody may be searching through the literature, through the publication system, finds some information on one case. So the power here is using artificial intelligence and machine learning to pull together all those 6 cases, all of that information into one repository, so that when Joe comes into that first paediatrician right back at home, they can put in the symptoms that you've seen, and those possible solutions will already come out. And Joe doesn't have to spend 3 years trekking through lots of different hospitals, having various different tests along the way. And I think that sort of artificial intelligence and learning, which will go on learning from Joe's case, putting his information into the cloud so that the power for the next patient will be even more, when that is coupled with all of the genetic information through whole genome sequencing, then we'll really be able to increase the power of making quick and also very accurate diagnoses.
That's great. Sure.
I want to add on that. I think you're spot on with what you're saying, both of you. And having a way where the patients and the families have in their possession their entire information packet, testing, diagnostics, symptoms. I know one of the things we spend a lot of our time on, even after all these other things have happened, is still pulling that together, and we still don't always get it all. So we don't go back down the same paths someone else has gone, so we don't repeat testing that doesn't need repeating. I mean, not only is it going to make us more effective, and it lowers the cost of the whole process too, which is one of the biggest barriers we have right now.
I think the other part of that is providing the legitimacy to what the patients and parents are bringing in. I just had another call just, 2 weeks ago from a parent in Canada again. Her daughter was initially diagnosed with autism. And so she goes into a whole bunch of programs for autism, et cetera, et cetera. Turns out, of course, 2.5 years later, and the mother keeps coming back to say, that's not it. What you're recommending is not right. She's doing it again. Recommending is not right. And again, she lives in a major, in fact, she works in clinical trials research at a major hospital. And she says, at least because she's got connections, she knew how to break through. 2.5 years to get a diagnosis of Rett syndrome. When, in fact, if she had had that proper information accessible to her, she could have come in with the right information and, as you say, been able to get, because this is a known condition. And, I mean, it's a tragedy when you have a country, like ours, where you've got all that information and really good, centers that are actually specialists in that disease, and yet a parent cannot get a diagnosis for 2.5 years, and in the meantime have not only been misdiagnosed, but the child has lost a lot of options in terms of what could have been, sort of retaining some kinds of functionality, et cetera. Yeah.
And I would say another challenge we have is, once we finished up the Human Genome Project, we all thought, we got all the answers now. What we realized is we were just getting started. And there is so much background information to fill in. And, we talked about, like, the case report. Well, do you have the time to write the case report up and the information on the different patients? So one thing I'm become a real big component of are programs like the one NORD is running, where we're actually creating patient registries with longitudinal history data that belongs to the patient organizations themselves. They actually have the biggest interest in maintaining and seeing those move forward. And I think that's one of the ways we create a sustainable system, because if we do these little one-offs, and you were talking about that, if we have a packet here, a packet there, how do you ever connect those things? And really our patients are the strongest way to do that.
I notice I spend a lot of time in hospitals, and the hospitals have these big monolithic electronic health records and are very limiting and not interoperable in many ways, and that's a challenge.
Yeah.
But as I started learning more about the rare disease community, going to things like Global Genes and seeing the kinds of organizations that are involved, there is a different kind of medical record that people are at least presenting to the rare disease community, one that's based on the patient controlling that record or the organization controlling it. And I actually think there's a whole new technology that could ensure the security of that. And we haven't even thought about that, and that's blockchain. Yeah. I really think that it has value in securing the pathway of that record.
Yeah, and that will massively improve efficiencies and duplication, the time it's taken by people in other areas to actually look and say, okay, well, this is not only what the patient knows, this is what all the doctors all the way along the chain.
Clifford, the presentation you gave was awesome in terms of thinking about the impact on a family, right? In terms of being able to plug that data and get an answer, or at least guided toward an answer much faster. What would you say to a hospital system or clinic that is wary of implementing technology like that, or any kind of pilots that could help us get answers more quickly?
I actually would welcome that. I think that's the thing that moves us forward. I'll start off by saying I would have loved to demo to you what this tool that I showed looked like 1.5 years ago. It really has improved, and a big part of that improvement is the physicians and clinicians at La Paz Hospital. And I can't wait till it gets into a hospital in the NHS or hospitals here in the US, because we'll start to see that. But what makes that work is that skepticism. I do think we have to engage with hospitals or with clinicians in hospital settings, providers in general, and find out what that skepticism is about, because there are many different reasons for it. Mm-hmm. I think one is some people think these tools aren't validated, and that's true. They're not properly validated yet. We really need to go through real rigorous IOB processes and scientific processes that are well established, and these tools need to be held to that higher standard in order to do this. So that's the first thing. But there are other things about AI that are disturbing, and I've just come back from HIMSS last week, and one of the talks that I went to that was most interesting was the bias and the ethical aspects of AI. It can be it can be misused very easily. And I'm sure that could be another skepticism. So, what is the bias that you're bringing into this? If you're only training a model on rare diseases and somebody puts in a normal genome, what's the tool going to do? Is it going to spit out a rare disease? So those are the kinds of things that we really have to start thinking about. A third area that we hear a lot about, and that could be an objection by somebody, is that this is data in the cloud. And is it secure? Is it private? And then my favorite hospital that really focuses on patient experience would say this if we took it to them. That's Cleveland Clinic. And they would turn around and say, the most important thing, as I ended my talk with, is not the technology, it's the empathy that goes into it. So how do you build empathy into this kind of technology as well? There are lots of ideas, but I think my view would be we need to talk to those.
Welcome the skepticism.
Welcome it, but in an open discussion, not a biased way.
Let me throw something on top of that, and I think you make an important point. For common diseases, you can do these at a few centers because they have a lot of patients. For the rare disease world, this kind of, I hate to say it, but almost this eating our vegetables process where we have to accumulate vast experience with these conditions, which makes machine learning and AI, I think, possible. We have to do it at multiple centers. The patients have to be involved. You really need a global effort because you've got backgrounds that will affect how these diseases present, whether it's in sub-Saharan Africa or it's in northern Canada. Those are going to have differences there, and we've got to pull that data together. As we do that, diagnostics get better, but we've still got, I think, a huge process in front of us that we need to do to really make those things hum. And I got to admit, I'm incredibly encouraged by how fast it's moving.
But I will say, though, and I think you raised a hugely important point, and that is not just the skepticism, but what do we do in terms of the patients and the public, quite frankly, right? Because at the end of the day, as you were saying, it's going to be the support. And then part of the question is, how do patients retain ownership of some of that? How do, so that's at the individual level, right? Exactly. So I'm given my information, I'm putting it in, what do I get back? How do I make sure that I continue to control how much it's used, where it's used, how else it's going to be used? And even as you say, it could be tremendous learning in an AI perspective, but how do I make sure it's not going to be used in ways that I, can no longer control? And I think we're getting some of those. I think the other thing that we're talking about, though, is making sure that we continue to engage, and that's why I've been so thrilled with this whole commission, is how do we build in patients and patient representatives right up front so that we can continue to talk about the issues like what are the ethics of it? What are the concerns that families are going to have in terms of, having this as part of, the information set that's out there? We all talk about big data, and I think for individuals, this kind of, in some respects, it's exciting, but it's a really scary thought. And especially as we see some of the kinds of concerns, even under the best conditions. So I'm really excited by, I think, where we're seeing this going. But I think it is our obligation to make sure we never lose sight, that we need to make sure that we're continuously going back to saying, how do we make sure that this is going to work? And I was very much impressed in being part of an EURORDIS, International Research Consortium on Rare Diseases project on a model consent form. And that, to me, is something we could think about. How do we actually have these kinds of global consents? So it's not only, but it's also education to the researchers, education to the clinicians, and also a safeguard to the patients, right, in terms of here's what the ethics are, here's what's being explained, here's what's being used universally. So I think all that technology is exciting, but as you say, let's not forget that at the end of the day, patients and parents need to feel really a part of it and feel really that they're being respected all the way through and continue to own it.
And how do we make sure that that's globally applicable and bring services to people and patients and families in areas where there aren't geneticists?
Exactly. Good. Because in most cases there aren't, right? Yeah. And I think that third thing, how do we improve the genetic counseling? So, I mean, I've had many people come back to me and say, and what do you do if you don't have a genetic counselor? Like, what do I do there? But are there ways that we could do it more remotely? Are there ways that we can, kind of tie into, as you say, sites and centers where there are? What's the obligation in terms of training up? The more we do this, the more we're going to have to train up the counselors, et cetera, to actually be available. So that becomes a human obligation, I think, if we're going to do this from a technology point of view.
I just thought of one more skepticism that I'm hearing. Some doctors, particularly specialists, think that these tools are going to replace them. And I actually ended up talking to a group of radiologists about 6 months ago, and the biggest concern in that audience when we spoke about AI and imaging and how AI was starting to be used on was they felt that their jobs would be taken away from them. And so, I think there's that piece that has to be dealt with as well.
I would, as a clinical geneticist of 30-plus years, I have no worries about that. There are more blue whales per people on this planet than there are clinical geneticists. The ratio is about the same, which we won't go there. But I think, to me, these will always be assistance tools. These are things that still have to be integrated with the patient, with the family. You still need someone who can interface, help get that information the family's bringing into a form where you can analyze it, because there's still some gaps there on how you put things in. If I use the word seizure, how many different seizure definitions are up there? How are you going to classify which one you put in? So, we have to do a better job on standardizing. I also still think, and this kind of comes back to some of the earlier discussions, having the patients drive the process moves the process faster. One of the things I've always found, medical centers and institutions tend to be fairly conservative. They tend to be more worried about what's the risk of us doing this. And then I'll have a family's like, I need an answer. And we'll push a little bit harder and faster. Now, they still need to be informed. They still need to know what the risks are. But I will find actually they'll drive the process faster.
So I've got one more question, and love for each of you to answer it. I think we've got 5 more minutes before we'll go into Q&A here. And it's, we all believe we've come up with some great ideas over the course of the last year coming together, but we have to implement them, right? What are the barriers that you think that we need to kind of get through, the skepticism, right, that's out there, that we need to get through in order to implement many of these and have, kids actually getting diagnoses much faster?
You want to start?
I think a lot of it's the interoperability of the system. So, for example, one challenge that I have actually is more in my work with cancer patients, but also with rare diseases, is that people have imaging, so x-rays, and they have them on different systems in different hospitals. And if I want to look at them, I have to get somebody to physically send it to me, either electronically or in post. So we're working on an electronic solution where everybody will be able to automatically see, without pushing or pulling, but see the imaging in different hospitals. I think those sorts of solutions speed things up and are real enablers in trying to improve diagnostic processes.
I would say clustering the information around the patient, not around the medical center where it was generated. And that speaks to interoperability. It speaks to, there's really not much incentive. We have our electronic medical records feel like the fruits of 1960s technology currently. There are some really bright spots there, but the systems are really not built more around patient diagnosis and care. They're built more around the administrative issues that come up around managing a patient, orders and things like that. So one of the departures I think we need to really make these things work is literally interoperable systems where the data follows the patient, not is locked to the medical center.
Wow, 1960s. I think I still had a black and white television. It was one of these little boxes, so I'm imagining what you're talking about here. I would
carry a handful of punch cards around.
Oh, that was my first thesis. I remember that too. The challenge for me, quite frankly, is kind of looking with an RDI hat, is how do we leave nobody behind? I mean, I'm looking at what you're talking about, I'm looking at what you're talking about, I'm looking at what you're talking about, and as we say, that might be great if you're in the environment where that can happen. The challenge is, how do we make sure as we're moving forward that we don't end up with, like the leading edge is going to be way out there, and we'll have all these fancy tools, and we have all these informed patients, but how do we make sure that we're bringing along everybody? And I think it's a huge opportunity to do that, but I think we have to think about that from the very beginning. It's sort of like when we're talking about the universal health coverage, and how do we get, rare diseases into this globally, and it means that as you're developing these systems, and we're encouraging, the WHO to say that for us, as countries, or emerging countries, are developing their healthcare systems, that they also include rare diseases, so we leave no one behind. And for us, that's the same challenge. We're developing these, and these are bright and shiny tools, but how do we make sure that we don't leave everybody else behind? And we don't have as an afterthought, there's many millions out there that we're not really addressing. And that's a big challenge.
Can I add a story on top of that? So we run a genetics clinic in Uganda about every year or every other year. And what we'll typically find is we'll find some teenagers with Down syndrome, one of the oldest diagnoses in the field in genetics, and one that a lot of clinicians can make but still gets missed, who've never been diagnosed. And chromosome analysis, which has been around for 40 years plus, that's the monthly clinic budget. You know what we did find, though? Everybody's got a smartphone. We can find a phone anywhere we go, and what we started doing was, we take pictures, and we get those digitally analyzed. And so I think one of the ways we reach into areas, we're not going to ever be able to train enough geneticists to meet all of these needs, and it's a model that we probably need to evolve. But we can use these expanders to get to the other one else. So even though we may be out here doing these things, I think we can build tools that are applicable in these situations.
That's right. That's wonderful.
Clifford, do you want to wrap up the discussion
I completely agree with you, and particularly accessibility. And there are just going to be so many areas of the world. I grew up and studied medicine in South Africa, and I can think about a child that I used to go and see, and this whole journey through rare diseases has made me think about this child with Sturt-Weber syndrome. But, you know, so I do think what you say is really important. The only thing I would add to that is all of that should happen, and we need it to be private and secure, because people won't accept it if it's not, and it'll be abused if it isn't.
All right, so we're going to take some questions from the audience. So we have a few folks with microphones walking around. Please wait until you've got a microphone so that folks watching online or in Brussels can hear as well. Yeah, go ahead.
My name is KP Singh. I come from Hong Kong Alliance for Rare Diseases. I'm also the council member of RDI. Thank you so much for the panel discussion, which is quite enlightening. My question is, I always see that many breakthroughs are coming from the science and technology, but I'm always query whether our clinical practice, our clinical protocols, and the healthcare system, and even the curriculum in medical schools can catch up with these breakthroughs to make it happen to the patients. What I mean is that always the breakthroughs may be rare practice in the medical field, but I want to have your answer how we can translate this rare practice into common practice in the diagnostic for rare disease children. Thank you.
That's a great question.
I'll take a swing at it since I run a clinical practice in a teaching medical school. The answer is that there's always a lag period. As the new developments roll out, getting them actually into the field, sometimes it wasn't invented here, so we're a little slower to adopt. Sometimes it's people don't talk to each other. I like to use the example of cystic fibrosis. This CF used to be a lethal disorder for teenagers. I watched a lot of patients in my career not survive that disease. And one of the things that the patient organization actually forced upon the medical community was sharing of treatment protocols, sharing of outcomes, and then actually going to the centers and saying, are you doing the same thing as the other centers are doing with this? And now, actually, the life expectancy in CF really increases almost a year every year because we don't have a back end on that yet. And so part of it is partnerships with the patient community. I can talk to another group of physicians till I'm blue in the face. They may or may not listen to me. When our patients are there with us, when they're advocating too, very hard to ignore. So the medical system itself is conservative. New things are often adapted slowly because sometimes there's worries they may be the wrong new things. But with our patients, I think we can accelerate that process.
Your question reminded me of another skepticism we should add when we talk about skepticism. The process, hospitals are not good at changing processes. You said they're conservative, they resist change, and that's could be another concern. You can see that almost any form of this AI that we're talking about is going to bring about some process change. The example I showed here, where a single-threaded approach today leads to a very different multi-threaded approach in the future. That we have to build into the healthcare system at the moment, and we have to have everyone from the patients to the providers starting to think about how you do real process improvement. And it's not just Lean and Six Sigma, because that's manufacturing, and that's fine. The concepts are fine. But there's something fundamental about a patient and what change means when you think of the journey that a patient goes through. And we need to do more of that. I'm glad to see there is thinking happening in countries around the world. I know some is happening in England. I've seen some in Sweden, New Zealand. I think people are beginning to think about process change in hospitals.
I think it's exactly as you said, though, because, you know, the fundamental systems, right, have to change. But you mentioned the Cleveland Clinic, which is also one of my favorite hospitals, having, you know, grown up in Ohio as well. But you know how they made the biggest fundamental change? It goes back to your empathy, right? I remember the story the VP told. She got, you know, there was a feedback from one of the patients who basically said her husband had this cardiac condition, da-da-da. You guys are rated at the top of the world in terms of technology. We're not coming there because you're rated number 10 in terms of empathy. We'd rather be at a hospital that had lower technology. And Cleveland Clinic basically said, oh, my gosh, this is not acceptable. And they turned around entirely, introducing all kinds of system changes, but most importantly, how do we educate our clinicians to actually be much more patient-centered? So I think absolutely that is the case. But it goes back, as you say, to that personal factor as well. But it's what you said as well. It's that patient being able to kind of have a portal for input that actually, in this case, reaches the very highest level where that system actually can be, that change can actually be driven.
I think we could answer this question. We could spend an hour. It was a great question. Are there others out there?
Oh, yeah.
Yeah. Oh, wow.
Oh, right.
Hi, hello, good morning. I'm Carlos Esteves. I am a father for 2 kids that maybe is a clear example that no diagnosis for 12 years, and it's an ultra-rare disease, seizures, and complement. I have 2 questions. The first one is, taking into account the Durhan words, what's happening with development countries? That is interesting, it's fascinating what happened with the machine learnings, and I have a very good approach what's happening with the kids. But what is the next step in order to get to implement the tools? Now, for example, in my country, maybe the karyotype is available, but not the genome sequencing. What happened in this time that the physician have the potential diagnosis, but not have the tools in order to get the final diagnosis? And the second question is, Health 29 is live now. We can enter and also choose and get some information in order to ensure the correct answer for the patients? Thank you.
So I'll answer the second one first. It's not live and available yet. It's still being tested, so it's a work in progress. There will be proof of concepts, and I think it needs to be scientifically validated. So we aren't there yet, but the effort of the Global Commission I hope is going to drive more and more of these technologies, including the kinds that Marshall was talking about, facial recognition and others.
And what I would say is we're in countries that are developing where, for instance, getting a whole genome sequence just isn't an option right now because of the cost of that. I think electronically we're going to lead. I think that's where the digital solutions are probably going to get out in front of a lot of what I would say the more classic lab hands-on based types of solutions. So facial recognition, algorithms for diagnosis where symptoms are coming in. Electrons are relatively cheap. Comparatively speaking, and software, once created, can be used on a wider and wider basis. The Microsoft folks are probably cringing as I say that. But it's true. You can actually scale those things up quite rapidly. And I would, well, like I say, what we're seeing in, I do a lot of work in Latin America and South America, and some of the digital tools we're using, we're far out ahead of where we are with things like the laboratory testing, things like that. Those are sort of that. We may eventually just run past them, where we're doing a lot of these things digitally. I hope so, because I think that's the only way we actually scale this up.
I think there are some other questions over here.
I only want to add what Carlo has already said, that in most countries, in developing countries, you don't have molecular study. Right. So we are leaving people behind.
Yes.
And that is a real issue in many countries of Latin America.
Thank you. Hi, my name is Lucas. Thank you for a great discussion already. My PhD is in rare genetic diseases and specifically tools like H29 and others, other algorithms of that nature. And I would argue that the biggest problem is not actually developing more tools like that, because there's a plethora like that already out there, and quite a lot of them work really well. So, for example, tools like this on the 100,000 Genomes project get diagnostic yields of 40% and upwards. I think the biggest challenge is actually distribution of those tools and not the development of the tools. So I'd be really curious to get some thoughts on how do you get tools like this in the hands of clinicians who are currently not aware of the fact that they exist or that rare genetic diseases are even a thing. And the second one is, all of these patient families exist online. So if you can't get the tools in the hands of the clinicians, how do you do distribution to those patient families and make sure that they find the right tools?
So
I think some of it comes back to what your colleague mentioned in terms of actually educating doctors, educating from medical schools. So why are rare diseases such a minor part of the curriculum when in fact in terms of numbers of patients as a whole, they're significantly broader in their representation. So I think it's about educating medical students, educating them not only about the conditions, but also about their technology, so that drive to use technology comes upwards as junior doctors come into the hospitals. We have medical officers who are in charge of information, and we often appoint junior doctors to those roles because they know they will grow with the roles and influence upwards as they go through the hospital. So I think that's really important. It doesn't address what's happening in parts of the world where the technologies doesn't exist. I think another part of it is standardization, when we've got such a lot of different applications coming through. How do we improve quality by standardizing and showing that we are really providing a connectivity which will enable everybody to work on the same sort of platforms?
You know, I'm listening to you. One of the things that comes to mind is we cannot make this like eating your vegetables. That's boring. Nobody wants to eat vegetables. Why do clinicians go to certain areas? It's not because that's necessarily where the biggest need is. It's where there's some interest, there's some excitement, right? I think we need to make diagnosing rare diseases really sexy. This is kind of like where the big tools are. This is like where the fun is. This is where things are going to actually happen. We need to sex this all up, right?
So that's a great segue for technology, because where there's been great innovation in tools that are widely used, it's been because people have created data sets that are available, de-identified, if need be, in certain cases, and that they put them out there for young, excited developers all around the world to work on. It doesn't happen in healthcare. I'll give you an example. Last summer I did some work in a class at Harvard where they gave them MBTA data in Boston. And the applications that these children came up with, and I call them children, they were 21 years old, but from around the world, were amazing. I mean, they were giving me my personal analytics on how I was using the MBTA and whether I was using it the best way, and they were calculating closest points to go to. Why don't we do that in healthcare? Why don't we create data sets that are de-identified and let people come up with great ideas? That's where you'll get this real exciting interest in it.
So what I'm going to add on top of what Durhane said, though, is without these data sets, without these data collections, okay, let's put some butter and salt on the vegetables so at least they taste good. But that, you know, these, like you said, the tools exist, but they're only as good as the information they have to work from to develop these algorithms. They can't work in a vacuum. So I think part of the thing we do is with the existing tools, we build these data sets like longitudinal natural history studies, like patient data collections, where those are pooled together. Then those algorithms become that much more powerful.
I'm just going to add one other thing, because when we, the work that I do at the Mighty is it's all about distribution, right? And I think what we've seen is that healthcare is not by nature very engaging, right? You want to go to a basketball game, you want to go see a concert, you don't want to go to the pharmacist, you don't want to go to your doctor. And so if we can make it more appealing, I don't know that I could go as far as saying it's sexy, but if we could make it more engaging, we think it's through personal stories. That is where people come together. It's relatable, and that's how we're trying to bring and build community together. Is really through that personal side. That's what people can relate to. They're much more likely to find the tool that we showed today if they may read a story and then it's attached right there. Like, oh, now I know what's in front of me. So I think that's a way that to actually make healthcare or make rare disease sexy is it's the personal stories. That is what's bringing folks together.
I just want to just add that endorsement, because if you have not seen the Mighty as a website and as a portal, it's amazing. And there's so many communities in there, and every single thing is driven by the stories. So you're going on there and you're learning a whole lot, and it's also great for patients in terms of sharing families. But out of it comes, as you say, some incredible learning. So if anybody has not seen it, it is such an incredible resource. I really salute in terms of what you've done with it. It's incredible.
Do we have one more question, or do we jump to Brussels? All right, so we're going to, I think Tasman Rose is going to join us from Brussels. She's been having a conversation there with a number of people, and she's going to join us and give us a little bit of a recap, I think, on what they've been discussing.
Hello, New York. This is Brussels calling. Can you hear us?
Yes.
Yes.
Good, excellent.
And we can see you
I'm
too.
not sure if you have any visuals yet.
Yep.
Can you see us?
Yes.
Yes.
Good, okay. As you say, we've had a really lively conversation. A small group of patients, policymakers, clinicians and researchers have been talking about where we go from here. And there was a real sense of excitement in the room that we are at a critical time. The momentum is finally moving forward. So we talked about how the elements of the Global Commission build on and strengthen the work that has been done at European level for 20 years on rare diseases, and the complexity of getting interoperability of data, medical health records and others, to flow within one national country where healthcare can be fragmented and then across borders. So this is an ongoing challenge, and we heard about different ways that the EU is trying to facilitate that process. But the message came through very clearly about the need to collaborate from primary healthcare, from the GP, the family doctor, right the way through to the specialist, and giving patients more power and more access and more hope throughout it all. We had some talk about data protection and ethics, and one of the questions that we actually wanted to put forward to you was to find out a little bit more about the H29 activity, because that sits in Europe, and of course we have the GDPR, which is the legislation that covers data protection, and there's been some concern that this limits the ability of use of data for further research. So we would like to hear how patient involvement and patient consent has been used in this pilot project to see what lessons can be drawn. But generally there is a commitment to the 3 tracks, a sense that it will help get things moving, and the intersection of technology, patients and clinicians together is on the edge of starting to make a real difference in people's lives. So the message I think we'd like to hear from is this pilot project that looks very interesting in Spain. How have you dealt with the issue of consent of data?
Can we jump to Spain to get the answer? I think Julian is listening in, but you can. No, I'm kidding. I would have to ask Julian and the team what they're doing. But I believe Julian is listening in on the call today because it's being live broadcast everywhere. So. I'm sorry, I can't. It's an important question. At a general level, we could talk about GDPR and what we think about doing, but I think you're asking specifically what kind of consent has been built into this tool. I think you're raising a great point, and I think we'd encourage Julian and the Microsoft team in Europe to work with you on this as well, and with us.
We'll make sure we put the 2 of you together after this call, and I'm sure he can answer the question.
Isn't Elena there at the... Is Elena
I am.
there?
I am.
Yes, she's right up there. They don't even know she's there.
So she can work with Julian. She's Microsoft's healthcare representative.
Yes, absolutely. I mean, I would say that the first thing is to be said is definitely, that solution, and actually Julian pointed it out. We received a lot of support from John Frank's team on making sure that it was up to standard in the implementation time of GDPR. But what you're asking is a couple of levels deeper, is specifically what type of consent, and that's what we need to check with the team specifically. Okay. It's a very, very good question, because it allows also how far we go on data collaboratives, data donation, data sharing, to take this one for much farther. Yeah.
I think here in Brussels we really recognize the potential contribution this could make to families to be able to get a faster diagnosis, and for a clinician, whether a family doctor or a specialist, to have access to the wealth of knowledge that AI and big data sets could give them. So I think the key message was, how do we make this happen? How do we remove any barriers along the way, whether it's public attitudes or legislation, to make it happen?
And let me throw something in. I noticed Pam Gavin's out in the office, out in the audience from NORD. She actually runs the registry program there, and it's one of the commissioners. This is the same problem we have with natural history studies in the U.S. If you base them at the academic institution, that typically means you have to reinvent the wheel as you go to each different academic institution, which in rare disease generates huge barriers because each one will want to put their own little spin on how the ethics are done there, and some of those are appropriate, and some of them that, in the U.S., Harvard doesn't trust Yale, and vice versa. What we have found, though, is when the patient organization is the driver of the ethical consent, and it still has to be done properly, it still has to be done, in the right format, that actually simplifies things because going through the patient organization, then the patients can consent back through their organization, and it's non-institution based. And that sounds like kind of a technical issue, but it actually suddenly frees you up to do a much wider collection where the patients are well informed but are also driving their own consenting.
Yes. Well, thank you guys very much for being a part of this, and I'm sure we'll learn more about all the discussion that you folks had there. And please, a round of applause for our panelists today. Okay, get up. So I want to throw it to Jan, who's going to give you the closing remarks of what we've done, really as a commission, and he can take it from here.
Thank you very much. So my pleasure to try to conclude this lively panel and discussion. So the colleagues in Brussels say technology, patients, clinicians, and I think we heard a lot that the drive comes from these three element, the drive of the technology, but also the drive of the patients, and that a lot of the changes that were mentioned is by having the patient driving the consenting, as Marsha was just saying, but also having the ownership of their data and taking responsibilities in accessing some of the care. So to express fully the potential of these technologies, we cannot separate from the policy environment. And we've worked in the Commission so that we look together at technology and policy change at the different level in order to have a full potential, a real impact to actually improve the time and the quality of diagnosis. I will go quickly through some of the policy recommendations that you have in the report. And first, we suggest that these policy recommendations be integrated, implemented through some of the policy work, which is now developing at the global level, progressively early steps, but at the United Nations and the World Health Organization. But even more so, where today there is strategies and policies in place, US, obviously, Canada coming to it, Europe all over, as it was mentioned, and as they are working in the member states and at the European level at new steps. But I would mention also the Asia-Pacific Economic Cooperation, the APEC, which is starting to work as a task force already on blood products, but is developing on rare diseases. And that's huge. That's huge. That 40% of the population, 60% of GDP. The benefit that we see for this recommendation is to improve efficiency, so encourage the use of disruptive technologies. It was mentioned several times. Blockchain. Blockchain is interesting. Maybe blockchain can be the passport for patients to have real ownership and control of their data and an history of the use of it, with all the questions of consent in the middle. Also the genetic sequencing, and maybe we need to see if the whole genome sequencing is the next frontier to go frontline or not. There is debate about it, but maybe it might be a first intention test in a certain situation. And also the advanced data sharing on diagnostic. And that has to go hand in hand, as I mentioned initially, and as it was mentioned during the panel, with innovation in the healthcare system. It's not just to plug this new technology and new approaches in the healthcare system as it is. It will help. Already we can progress, but we need to transform some of the healthcare system. And a key question in the middle is the cost. We believe in the Commission that these new technologies and advances can help reduce the cost. Now we need to make the proof of concept of that a little bit more to be fully convincing. But that's the direct, at least that's what we believe, and we also need to work from what we believe, not only from the facts. And the third benefit that we see is that these technologies are empowering the patients, not only the patient advocates and the groups, the collective, but the individual in their journey through the healthcare system and with their diseases. And I would insist on one element is a journey over time also. So from one hospital to another, but also over life, from transition between children and adults, or when you're moving from one region to another, or from one country to another, or at different steps in your life. Well, recommendations are focusing in 4 key areas. The centers of excellence. And you heard it from the panel and from Marshall, for instance, that the national healthcare system needs to develop these centers of expertise, but also we heard from our colleagues in Brussels the link between the primary care and the centers of expertise. And that's essential. So we need to raise awareness of the primary care providers, and we need to have a link, the referral to the centers of expertise. Second element is the data sharing, the level of global benefit of the cloud, potentially, data storage, although there is the debates on the legal and regulatory aspect here, not to mention the Data Act and the discussion. So that raises immediately some concern. But every proposals and pilots that are in the Global Commission are respecting the European regulation on data protection. That is a commitment that is made into it. And the data sharing is also about the interoperability that was mentioned on several occasions. And that, so the policy, the health policy in our different countries or at the international level should encourage the data sharing across borders to increase the likelihood of match also of the most rare diseases internationally. Few examples of this recommendation include the government support to national umbrella organization of patients or international platforms, but also platform of dialogue between patients and all stakeholders in this area of rare diseases. The pilot presented by Clifford, when they will be mature and upgraded, can really be transformative, because we don't need to wait for the healthcare infrastructure to develop all over the world. We can already take action. And we see this tool not only to be used by clinicians, but as it was mentioned, also used by the patients and the families themselves. Not to have a diagnosed, but to know where to go much faster. So we can be on this front line, exactly like today we're booking our plane when we used to go to an agency before. Here we would be already doing the triage ourselves of all issues to speed up, because we are concerned, we want to go fast, right? Standardization of diagnostic and referral protocols is another recommendation for primary care and centers of expertise, but that goes with the infrastructure for the development of the sequencing. And the primary care technical training to incentivize the adoption of these technologies, and that's part of the adaptation of the healthcare system. We need the people to be trained in hospital, but also outside the healthcare providers to accept these innovations. Now, to conclude on this, I would encourage everyone to disseminate the reports and the recommendations. Try to take action from it. As it was said by one of the participants, not only to develop the tools, but to distribute the tools. Thank you for saying that. That's really, I think, a key element in what we're doing. And I'd like to mention also, to make comment, that this Global Commission is the first time for EURORDIS as a patient organization that we've been working with private actors for a scientific committee. Until now, it has always been embedded into the European Commission, the European Medicine Agency, or the United Nations. So it was a first, it was a risk, and we have no regret. This premiere for us is a success. We're happy with the outcome. We committed to disseminate and to encourage our members to disseminate the outcome. But also, I would make the link with the Sustainable Development Goals of the United Nations, the Agenda 2030, where the 17th and last Sustainable Development Goals is about partnership and public-private partnership. And here we can set this Global Commission as a good practice, as an example of where to go, and try to promote it along this line. And this first report is presented back-to-back to an event taking place tomorrow at the United Nations as a policy event, in fact, of Rare Disease Day. And many of you in this room will participate tomorrow. And the objective of this event is to reaffirm that rare diseases are part of the United Nations Agenda 2030, of the Sustainable Development Goals, with the theme of leaving no one behind. If we are serious about leaving no one behind at the United Nations and the member states, then rare disease comes in. And that's where we're going. That's where we're progressing. And tomorrow also we want to promote universal health coverage for rare diseases, to have rare disease into the political declaration coming up in September. And what we will call for tomorrow, with the support of 15 member states in the room and agencies of the United Nations, is to call for United Nations resolution to address the challenges of people with rare diseases. The Global Commission is part of that effort, of the global efforts, and there is not only this one. There is the EURORDIS, the International Consortium on Rare Diseases. There is different organizations which are stepping up to take global action. And bringing together the actors in technologies, in health and in digital, but also in other areas, physics, nanotechnologies, imaging. I mean, there is more than this area, right? And also bringing together the innovation again in the healthcare system. We need to promote this innovation. And rare diseases, being at the margin of the system, can be transforming and becoming mainstream, because a lot of what we do and what we're doing in this Global Commission can apply much broadly beyond rare diseases. We are at the margin of society and science, but we're creating the mainstream solutions of tomorrow. That's at least what I would believe. And with that, I would like to thank all participants in Brussels for being with us, and the colleagues from the European Commission, particularly Stefan Schreck, also being with us. And I'd like to thank my two co-chairs and all participants in the panel today. You've been fantastic. And to all of you for attending today. Lunch is just outside for the one in New York, for the one in Brussels. We leave it to you to decide where you have dinner. Thank you.